The COVID-19 pandemic has exposed the deep flaws and inequalities in the current healthcare regulations around the world. Millions of people have suffered and died from the virus, especially those who belong to vulnerable populations, such as the elderly, the poor, the chronically ill, the mentally ill, the racial and ethnic minorities, the migrants and refugees, and the informal workers. In this section, we will explore how the current healthcare regulations fail to protect these groups and why they need to be revised urgently. First, let's look at some of the facts and figures that show the disproportionate impact of COVID-19 on vulnerable populations. According to a report by McKinsey, about 20% to 30% of the global population is health vulnerable, meaning they have chronic health conditions or are over the age of 65. These people are more likely to develop severe COVID-19 symptoms and require hospitalization if infected. However, many of them face barriers to access quality healthcare services, such as lack of insurance, affordability, transportation, language, or discrimination. Moreover, many of them live in crowded or unsanitary conditions, work in essential or informal sectors that expose them to higher risk of infection, or lack social and economic support to cope with the pandemic. For example, in the United States, health-vulnerable people account for about 30% of the population but represent about 80% of COVID-19 deaths. Among them, racial and ethnic minorities have been hit particularly hard. According to the Centers for Disease Control and Prevention, CDC, Black Americans are 2.8 times more likely to die from COVID-19 than white Americans, while Hispanic Americans are 2.3 times more likely. Similarly, in Europe, migrants and refugees have faced higher rates of infection and mortality due to COVID-19, as well as discrimination and stigma. Many of them work in low-paid or informal jobs that lack social protection or health coverage. They also face challenges in accessing health information, testing, and treatment due to language barriers, legal status, or fear of deportation. These examples illustrate how the current healthcare regulations have failed to protect the most vulnerable populations during the COVID-19 pandemic. They also show why these regulations need to be revised to ensure more equitable and resilient health systems. Some of the possible actions that governments can take include collecting and reporting disaggregated data on COVID-19 cases and outcomes by age, gender, race, ethnicity, socioeconomic status, disability status, and other relevant factors to identify and address health disparities. Expanding health insurance coverage and affordability for all people, especially those who are uninsured or underinsured, through subsidies, waivers, or public options. Increasing access to primary care, preventive care, mental health care, and telehealth services for vulnerable populations through community-based outreach, mobile clinics, or home visits. Providing adequate personal protective equipment, PPE, testing kits, vaccines, and therapeutics to health workers and vulnerable populations in a timely and equitable manner. Enhancing coordination and collaboration among different levels of government, health authorities, civil society organizations, and international agencies to share best practices and resources for tackling COVID-19. Addressing the social determinants of health that affect vulnerable populations' exposure and vulnerability to COVID-19, such as poverty, housing insecurity, food insecurity, education inequality, environmental injustice, or violence. Promoting public awareness and education on COVID-19 prevention and treatment among vulnerable populations through culturally appropriate and linguistically accessible communication channels. Combating discrimination and stigma against vulnerable populations in healthcare settings and society at large through legal protection, enforcement mechanisms, or anti-racism campaigns. By implementing these actions, governments can revise their healthcare regulations to protect the most vulnerable populations during the COVID-19 pandemic and beyond. This will not only save lives and reduce suffering but also strengthen the resilience and equity of health systems for future crises. In this section, we will explore some concrete examples of policy changes or reforms that can help achieve a more resilient and equitable healthcare system in the United States. These are not the only possible solutions, but they illustrate some of the key principles and strategies that experts have proposed to address the gaps and weaknesses of the current system. One example is expanding Medicaid, the public health insurance program for low-income Americans. Medicaid covers about 74 million people, or 1 in 5 Americans, and provides essential services such as primary care, mental health care, maternal and child health care, and long-term care. However, not all states have chosen to expand Medicaid under the Affordable Care Act, ACA, leaving millions of people uninsured or underinsured. Expanding Medicaid would reduce the number of uninsured Americans by 12 million, improve access to care and health outcomes for low-income populations, and reduce racial and ethnic disparities in health coverage and care. It would also reduce uncompensated care costs for hospitals and providers, and generate economic benefits for states through increased federal funding and job creation. Another example is strengthening public health infrastructure, which is the backbone of a resilient health system. Public health infrastructure includes the systems, capacities, and resources that enable public health agencies and partners to prevent, detect, and respond to health threats such as infectious diseases, natural disasters, environmental hazards, and chronic conditions. The COVID-19 pandemic has exposed the chronic underfunding and understaffing of public health infrastructure in the U.S., as well as the lack of coordination and integration with clinical care delivery. Strengthening public health infrastructure would require increasing and sustaining federal, state, and local funding, investing in public health workforce development and retention, enhancing data systems and surveillance capabilities, building community partnerships and engagement, and promoting a culture of health equity and social justice. A third example is reducing health disparities, which are differences in health status or outcomes that are linked to social, economic, or environmental factors. Health disparities affect many groups in the U.S., such as racial and ethnic minorities, low-income populations, rural residents, women, children, older adults, people with disabilities, and LGBTQ+ individuals. Health disparities are not only unjust and unfair, but also costly and harmful to the health of the nation. Reducing health disparities would require addressing the social determinants of health, which are the conditions in which people are born, grow, live, work, and age. These include factors such as income, education, housing, transportation, food security, neighborhood quality, social support, discrimination, and access to health care. Addressing the social determinants of health would involve implementing policies and programs that improve living standards, reduce poverty and inequality, protect human rights, and ensure universal access to quality health care. A fourth example is promoting health literacy, which is the ability to obtain, process, and understand basic health information and services needed to make appropriate health decisions. Health literacy affects people's ability to navigate the health system, communicate with providers, manage chronic conditions, prevent diseases, and adopt healthy behaviors. Low health literacy is associated with poor health outcomes, higher healthcare costs, and increased health disparities. Promoting health literacy would require improving the communication skills of health professionals, simplifying health information materials, increasing access to reliable and accurate sources of health information, and engaging patients and families in their own care.